Hello, everyone. Okay, so I'm Edwin. I'm one of the PGY2s, and I'm going to talk to you guys, continuing with the HEMONC topic with chemotherapy-associated toxicity. All right, so brief overview. We'll start off with a case presentation that we'll come back to later down on the slides. Then I'll just do a quick overview of some common chemotherapies, especially just because there's tons of them, and every time I see a chart with chemotherapies, I just need to Google all the names. Then we'll talk about some common manifestations of chemotherapy toxicities, things we might be more likely to see in the ED, and then I'll dive into a couple specific chemotherapies in terms of their toxicities because their management is a little bit more specific and they can present a little bit more dramatically. So starting off with the case presentation, you're in CCT, you get a notification. There's a 54-year-old male coming in, unknown medical history, coming in for severe respiratory distress. Upon arrival, he's altered, he's dyspneic. His vitals, as seen here, he's 80% on 15 liters of iron rebreather. He's hypotensive to 150, tachy to 124, tachypnic to 35. Exam-wise, quickly you take a look at him. He has bilateral pitting edema, diffuse crackles on exam, cold, clammy extremities, and weak distal pulses. All right, so at this point, what do we got thinking so far? Exactly. So this picture is that of a cardiogenic shock, and we'll come back to this. Just keep this vignette in mind as we talk about certain chemotherapies that are associated with this type of presentation. So going over just kind of a basic common chemotherapies that are used in patients, right? They usually like to break down chemotherapies into 5 distinct categories, right? We have the alkylating agents, which, the most common ones include cisplatin, carboplatin, cyclophosphamide, right? And these really work, it's in the name, they work by essentially DNA alkylation, and they inhibit further DNA synthesis by essentially causing, inserting themselves into the DNA and preventing it from continuing to replicate. Then we have the antimetabolites, which are also, we can commonly see not even just in cancer therapy, such as methotrexate, but also includes 5-fluorouracil, also known as 5-FU, or capecitabine, which is just the oral form of 5-FU. These really focus more on targeting specific nucleotide synthesis. So getting back to our biochem, they target either purine, thymidine synthesis, sometimes uridine synthesis, and they prevent further DNA replication by targeting these specific nucleotides. Then we have the antibiotics such as doxorubicin, the anthracyclines that they include as well, dactinomycin, bleomycin you might see as well. These work via different mechanisms depending on the exact chemotherapy, but for the most part, they will also focus on inhibiting DNA synthesis, and some of them, like doxorubicin, can also cause free radical formation that can further cause cell death and cell apoptosis. Then we also have the antimitotics, right? These are the vinblastine, the vincristine, the paclitaxel, and these work mostly by affecting the microtubules and prevent either destabilizing them or inhibiting them from forming, and in turn, during mitosis, preventing further replication of the cell, targeting really high replicating cells, which are usually going to be the cancer cells. And then lastly, we have the more targeted therapies that will include, your monoclonal antibodies, your protein kinase inhibitors, your estrogen receptor antibodies, and these really will specifically target certain cell receptors, such as tamoxifen that we see in breast cancer and stuff like that. But this is just kind of a quick overview. Now, with a lot of these agents, like I said, most of them are going to be targeting cells with really high mitotic activity, right? So that's going to include obviously the cancer cells, but as a result, they're also going to include other cells such as intestinal epithelial cells, follicular, hair follicles, stuff like that. And this is why you get patients that will present kind of with these common side effects, as one would say. Nausea, vomiting, mucositis is very common, especially in the early stages of someone starting chemotherapy, alopecia, as I said before, bone marrow suppression, which is why, oftentimes if we ever are seeing a chemotherapy patient in the ED, we're most likely always going to get labs to rule out any underlying infection, anemia, thrombocytopenia as a result of that as well. Like I said, the nausea, vomiting usually comes from stimulating the chemoreceptor zone in the medulla, and that can lead to sometimes intractable nausea, vomiting. A lot of these patients will suffer from that. Diarrhea, fatigue, peripheral neuropathies. These are kind of common side effects that you might see just from a patient that's just on normal chemotherapy. And for the most part, a lot of these management of a lot of these symptoms is just going to be supportive treatment, right? So it's going to be IV hydration, antiemetics, pain control depending. And then, like I said, usually often you want to rule out any underlying infection in these patients. So now we're going to go and talk a little bit more in depth about three specific classes and their special presentations. The first one will be that of the anthracyclines, right? So back to our previous case, we were talking, right, about a patient who came in pretty much in cardiogenic shock, right? You're in that case, and then you are, after you're able to stabilize the patient, you finally have some time, you chart review, you find a family member, and you find out that this patient is actually being treated for some sort of osteosarcoma, recently started on doxorubicin, probably like a couple months ago. The reason we bring this up is because of doxorubicin-associated cardiotoxicity. So doxorubicin is used in a lot of solid tumors, but also can be used in hematological malignancies. So it can be used in lymphomas, can be used in breast cancers, ovary cancers, GI cancers, right? And anthracyclines, specifically doxorubicin, are known to cause toxicity in different time periods, right? You can have doxorubicin toxicity, cardiotoxicity in acute, subacute, or in the chronic settings. The mechanism of action is actually not completely clear. One theory is of the thought of the generation of these hydroxyl radicals that can then cause DNA disruption and then can cause cardiac myocyte death. I think learning back in med school, there was also the idea that sometimes it would target kind of the same structure that was in the cardiac myocyte, which is why they had propensity to have cardiotoxicity. As you can see here in this echo, this is just an example of a dilated cardiomyopathy, which can be a late finding in patients who have been on doxorubicin for some time. You can see the almost spherical looking left ventricle, the really poor EF. And this is just something to definitely keep in mind. In regards to the timing, right, acute toxicity with doxorubicin really can present with a wide variety of cardiac issues, including dysrhythmias. They can have ischemic changes, right? And this can be as acute as within the first 24 hours. They can also have a pericarditis or a myocarditis that forms. Then subacutely within weeks, this is kind of the really dangerous time period because at this point, they can develop this myocarditis with severe diastolic dysfunction. And in these patients, they have a really high mortality. And then chronically, they can progress to this dilated cardiomyopathy, as was seen in the slide before, have pretty bad CHF or LV dysfunction. And the unfortunate thing about this is that toxicity is cumulative and is dose dependent, but it's also irreversible in most cases. So it's definitely something to keep in mind if a patient just so happens to say that they are on doxorubicin. In terms of the management for this, right? First, as in the patient that presented CCT, you're going to need to always focus on your ABCs and stabilizing the patient, right? You always want to keep a broad differential and remember to exclude other common causes of cardiac symptoms, right? Not just because they're on doxorubicin, you're going to jump and say that's doxorubicin toxicity. They might actually have CHF on top of that. This might be an actual acute CHF overload, or there could be other causes as well. So management in this case, for the most part, will be similar to management from all the other cardiogenic causes, right? In this case, labs, EKG, chest x-ray, you can do a bedside echo. If they are in severe cardiogenic shock, they'll probably have to be on vasopressor and inotropic support and require ICU admission. And they definitely, if you are concerned of a doxorubicin toxicity, then you definitely want to avoid any further anthracycline exposure. One thing to keep in mind is that though this is not something we would usually give in the emergency room, desrazoxin is a drug that some of these patients might also be on. And essentially it works by inhibiting some of the free radicals that doxorubicin causes, and is usually given in patients who are chronically on doxorubicin as a kind of preventative measure. It's been shown to lower a little bit of the incidence of CHF and LV dysfunction. Now, the next class of drugs that we'll talk about is methotrexate. This is definitely a very common one that we see, not just in oncological cases, right? Methotrexate is used for a wide variety of malignancies, right? Rheumatological conditions, as well as an immunosuppressant in many transplant patients, right? This functions as a structural analog to folic acid, and the way it really works is it prevents DNA and RNA synthesis by inhibiting the specific enzyme, the dihydrofolate reductase. In doing so, in turn, as seen in this very complicated biochemistry diagram, will prevent de novo purine synthesis and therefore prevent further DNA replication by targeting that specific nucleotide. The toxicity of methotrexate really will depend on the dose, will depend on the duration of administration, and most importantly, will depend on the renal clearance, right? So any patient who will have, for some reason, some sort of altered renal clearance, you definitely want to be, you want to keep in mind that they might be having methotrexate toxicity. Now, the clinical manifestations of methotrexate toxicity include nausea, vomiting, nausea, vomiting. They can have cutaneous manifestations. They can have a mucositis, stomatitis, as we talked about before. They can also have the myelosuppression, the pancytopenia. But really, the most important thing you want to look out for with methotrexate is going to be the renal injury. And this is usually secondary to precipitation of the crystals within the renal tubules. They can also present with hepatotoxicity in certain cases and neurological manifestations, which can include hemiparesis, seizures, quadriparesis, and sometimes even coma, and that could be within hours to days of recently starting methotrexate. In terms of the management, really the main thing for methotrexate toxicity is you want to determine if it's a chronic versus an acute exposure, right? If it's an acute exposure, then you're going to want to give them IV hydration and try to alkalinize their urine. Usually you alkalinize their urine by either starting them on a bicarb drip or inserting a few amps of bicarb into IV fluids and running that fluid. And the reason for this is by alkalinizing their urine, you're going to be able to essentially prevent the buildup of those metabolites in the renal tubules. Additionally, if they're taking a PO, you can consider activated charcoal if they are arriving within a certain time period. For chronic exposure, right, higher on the differential, you're going to be more worried about just immunosuppression. And so you're going to want to rule out any sort of underlying sepsis and also look at just their baseline kidney function and hepatic function, since long-term use of methotrexate, like I said, can cause renal injury and transaminitis. Yep, Dr. Jean?
Did you run across anything about using folinic acid as an antidote?
That's my next, Dr. G is on it. So in the acute phase, you definitely, there is a few antidotes that we want to keep in mind, and that's why it's important to know this for methotrexate. The first one is the drug name is called leucovorin, or folinic acid, as Dr. G just said. So the way this works is folinic acid, like I said, methotrexate works by inhibiting the dihydrofolate reductase. Folinic acid doesn't require that enzyme for activation. So essentially will bypass that entire inhibition and will help promote the synthesis of the nucleotides that are being blocked. However, it is important to know this drug is often a multi-day treatment, and it's as seen here kind of in the picture, it's leucovorin with calcium, so it can cause hypercalcemia if you're giving it in huge dose. The usual dose is usually around 20 mg IVIM Q6, and you want to be measuring methotrexate serum levels alongside with it. You can give an empiric dose, I was reading, of like around 100 mg over 15 to 30 minutes, and sometimes that could be good for acute toxicity. You also want to keep in mind with this drug that in patients who might have ascites, who might have pleural effusions, or just other issues that might cause the half-life of methotrexate to be prolonged, you might want to give longer dosing and higher dosing, because the methotrexate serum level won't accurately reflect the actual concentration. The other drug to keep in mind with methotrexate toxicity is called glucarpidase. And glucarpidase is essentially an enzyme that will help break and cleave the methotrexate folate complexes that form when methotrexate is administered. For glucarpidase, usually you want to give it after you've already given aggressive folinic acid with it. And you usually also want to have a serum level of methotrexate, because usually the indication to give it, it's been approved to give it as long as the serum level is greater than 1, I believe, micromole per liter with the presence of renal dysfunction. So it has kind of specific indications to use. And additionally, it's important to note that you don't want to give glucarpidase 2 hours before or after you've given the folinic acid, because it can cause inactivation of the folinic acid. So you want to really, the first line is going to be the folinic acid, and then you can consider glucarpidase if necessary. And then the last kind of step, since if it is acute enough, it presents acutely enough, you can consider dialysis, but you have to keep in mind that it has to be early enough, because methotrexate will distribute pretty widely into the peripheral tissues. And so if you don't catch it early enough, dialysis won't really be that helpful. Then the last class of chemotherapies that I'll talk about is 5-FU and capecitabine, right? So 5-fluorouracil and capecitabine, very common chemotherapies that are used mostly for GI cancers, colorectal specifically, as well as breast cancers. 5-FU and capecitabine, they both work by, again, targeting this, in this case, uridine, and in turn, which is one of the nucleotides, and in turn disrupting the further synthesis of DNA and RNA. Capecitabine is simply just an oral prodrug of 5-FU. So 5-FU usually patients will go to chemo centers and get it through an IV, get it through a pump. Whereas capecitabine, it's essentially just an oral form of that that converts into 5-FU once it reaches the gut. The clinical manifestations of toxicity here, most commonly you're going to see in if someone presents CDD, it will be usually gastroenteritis, obviously bone marrow suppression as well. They can present with what is called this hand and foot syndrome, which essentially you just see erythema. You can see erythema, edema, pain of the palms. You can sometimes get skin desquamation. You can also see it in the soles of the feet as well. Cardiac toxicity is there, but it's very rare. And neurotoxicity can also present with confusion, encephalopathy, and coma. Now, the management for this type of toxicity, as with other PO overdoses, if a patient comes in with an intentional overdose of their capecitabine, which is the oral form, you could consider activated charcoal. But the main kind of antidote for this type of toxicity would be this uridine triacetate. So uridine triacetate, essentially the way it works is that it will, in the gut, it will acetylate and essentially form the uridine that is being blocked, whose production is being blocked by the 5-FU or the capecitabine. And so it provides a new source for DNA and RNA synthesis. The main indications for this include if it's a known overdose, regardless of the presence of any sort of clinical toxicity. So if someone comes into CCT and they had 3 empty pill bottles of capecitabine right at their bedside, and you're pretty sure that they're having a known overdose, and that's an indication. Second is going to be early onset of life-threatening or severe toxicity, right? And then the third one will be early onset of like unusually severe adverse reaction, usually if they're having really severe gastroenteritis within the first 96 hours or neutropenia. You can consider giving uridine triacetate. Usually for this, you will also want to treat, you can also get plasma uridine levels to kind of measure kind of the progression of all of this. So in summary, we went over 3 main classes, right? The anthracyclines or doxorubicin, right? Keep in mind, these can present with, in the most severe cases, and severe cardiogenic shock, right? There's no real antidote to treat this. You want to treat whatever active condition they're presenting to you with. Methotrexate, on the other hand, right? You want to remember your folinic acid, your glucarpidase, and possibly sometimes your hemodialysis, depending on how early they present. And then 5-FU and capecitabine, you want to consider uridine triacetate. Additionally to all this, right, you always want to check your ABCs. You want to stabilize your patient and keep your differential broad, because patients on chemotherapy are going to have lots of other medical problems, and definitely don't want to just pigeonhole on one of their chemotherapies. But otherwise, that's pretty much it. Thank you, guys.